Bismillahirrahmanirrahim. Assalamu alaikum. Welcome back. In today's lecture, which is the last one of the workshop, we shall be discussing key guidelines for managing cirrhotic patients during Ramadan fasting. Fasting can pose significant challenges for individuals with liver disease, and proper management is essential to ensure their safety. We shall cover important medical considerations, risk assessment, dietary recommendations, and when fasting may not be advisable. Stay tuned for expert insights on how to navigate Ramadan safely for cirrhotic patients. Today is the last lecture of our workshop, and we shall discuss the key guidelines for managing cirrhotic patients during Ramadan. The guidelines on the management of cirrhotic patients during Ramadan. Managing cirrhotic patients during Ramadan requires a careful balance between respecting their religious practices and ensuring their health and safety. Physicians should provide individualized recommendations considering the severity of the liver disease, coexisting conditions, and overall patient health. And this workshop has been an attempt to ensure that the proper decision is made for the patients, keeping the severity or status of the health of a cirrhotic patient, and of course the religious obligations and requirement of Ramadan. These guidelines, they have dedicated sections. They are about what should be the pre-Ramadan assessment of these patients. What about the patient education and counseling? Fasting guidelines based on disease severity. If a patient is compensated cirrhosis child class A or decompensated cirrhosis child class B or C, then of course the hydration and nutrition strategies. What about the regular monitoring during Ramadan of those patients who fast? When to advise cessation of fasting? And what should be the post-Ramadan care? So these guidelines, they have dedicated sections, and we will review these guidelines under these headings. First, the pre-Ramadan assessment. The pre-Ramadan assessment has different components. First, to evaluate liver function. Second, to do the nutritional assessment of these patients. Then to look for the coexisting conditions. To evaluate the liver function, you need to do the liver function tests. Assess for any signs of decompensation like elevated bilirubin, ALT, AST levels. Calculate the child peak score This score A, B, or C helps classify the severity of cirrhosis. We know that. Patients with child class C or decompensated cirrhosis should be advised against fasting. Then the MELD score, calculate this, the model for end stage liver disease. It's useful for assessing prognosis and risk for complications. Regarding the nutritional assessment of these patients, assess for malnutrition or sarcopenia. Patients with poor nutritional status should receive nutritional support before Ramadan. Weight loss and fluid retention. Determine if the patient has any signs of ascites or edema. And then the coexisting conditions, that is the third component of pre-Ramadan assessment of cirrhotic patients. Diabetes mellitus. Cirrhotic patients with diabetes may experience fluctuations in blood glucose levels during fasting. Their diabetes management plan must be adjusted. Hypertension and cardiovascular health. Control of blood pressure is essential for prevention of complications during dehydration. Now, the second component of these guidelines, that is the patient education and counseling. This comprises health risks for fasting for cirrhotic patients, how to educate them on those, and to educate them on self-monitoring and early warning signs. We should explain to them the health risks of fasting for cirrhotic patients, explain the potential risks of fasting, including dehydration, hypoglycemia, hepatic encephalopathy, and electrolyte imbalances. Tell them that these are the particular risks which they can have. And then inform patients of the exemption. Tell them that the Islam has provision for those who are ill or have chronic conditions. And it allows them to either break their fast or compensate by feeding the poor. If the patient is fasting and the condition worsens, so he or she can break the fast, and even they can avoid the fast on the subsequent days and giving fidya. What about the self-monitoring and early warning signs? Encourage the patients to monitor themselves for symptoms such as dizziness, confusion, weakness, fatigue, dark urine, or signs of dehydration. If they develop these, then they may break their fasting or they may avoid the fasting. Advise patients to break the fast immediately if these symptoms occur. Now, the third component of these guidelines is on the fasting guidelines based on disease severity, but for those who are having compensated cirrhosis. It has the subcomponents of possible to fast with monitoring and dietary guidelines, and of course the medication adjustments and monitoring of such patients. So, the possible to fast with monitoring, there is an option for these patients. Patients with stable compensated cirrhosis, that is Child-Pugh A, may be able to fast with close monitoring, especially if they are not experiencing ascites, encephalopathy, or severe malnutrition. What about the dietary guidelines to these patients? In the suhoor, that is the pre-dawn meal, they should have high protein, high complex carbohydrate diet, and fiber-rich foods to maintain energy levels throughout the day. They should avoid salty foods in the suhoor. In the iftar, that is the breaking the fast, they should have balanced meal with adequate protein, carbohydrates, and healthy fats. And they should ensure good hydration with water and electrolyte-rich fluids during the time period between iftar and suhoor. and they should avoid heavy, greasy foods. The third component of fasting guidelines and disease severity is about the medication adjustment. Ensure medications that affect liver function, such as diuretics and lactulose, are properly timed, typically after iftar. Adjust doses of diuretics if needed to avoid dehydration and carefully monitor renal function. Regarding the monitoring, blood glucose monitoring should be done. Check glucose levels, especially for patients with diabetes. Modify insulin or oral hypoglycemics as necessary. Electrolyte levels. Monitor for electrolyte imbalances, especially potassium and sodium, and correct as needed. The decompensated cirrhotic patients, what are the fasting guidelines for them? Again, there's a statement that strongly advise against fasting. Alternative recommendations you should offer them, you should tell them, you should educate on them. And of course, managing decompensation risks. Decompensated cirrhotic patients, child class B and C, involves complications such as ascites, jaundice, varices, and encephalopathy, making fasting risky due to the high risk of dehydration, electrolyte imbalances, and worsening liver function. So if your patient has got any of these complications and he or she is in child class B or C, then strongly advise against fasting. The alternative recommendations, you educate them, you tell them that there is exemption from fasting, advise patients not to fast, and reassure them that they are not breaking their religious obligations. They can compensate by feeding the poor or fasting at a later time with their health. When their health improves, they should give the fidya. Managing decompensation risks. Optimize diuretic therapy to manage ascites and edema. Ensure lactulose is properly treated to prevent hepatic encephalopathy. If they present with these complications to you, it's a standard protocol. Follow the standard protocol. Monitor for renal dysfunction, hepatorenal syndrome, and consider withholding diuretics if renal functions declines. The fourth component of these guidelines, these are the hydration and nutritional strategies. And this includes fluid intake, electrolytes balance, meal planning. In the fluid intake, instruct patients to drink at least 2 to 3 liters of fluids during non-fasting hours between iftar and suhoor to prevent dehydration. If cirrhotic patient is fasting, so this is very important, encourage the fluid intake. For patients with ascites or edema, hydration should be monitored to avoid exacerbating fluid retention. And of course, when they have got these complications, we advise them not to fast. Electrolytes balance. Encourage the intake of electrolyte-rich fluids like oral rehydration solutions or coconut water to prevent hyponatremia, which can worsen hepatic encephalopathy. If these patients, they are fasting, they were in compensated cirrhosis and you allowed them to fast. Adjust diuretic therapy if the patient is prone to electrolyte imbalance. Meal planning in the suhoor should include low digestive foods, that is the whole grains, legumes, to maintain energy and reduce hunger during the day. In the iftar, focus on a balanced meal with proteins, vegetables, and complex carbohydrates. Avoid high-fat, high-sodium foods that may exacerbate ascites or hepatic function. The fifth component of these guidelines is about regular monitoring during Ramadan, and it includes close follow-ups, blood glucose managements, assessment of ascites and encephalopathy. The close-up follow-up, arrange for regular follow-ups appointments during Ramadan to monitor liver functions, electrolyte levels, blood glucose, and nutritional status if these patients are fasting. Frequent blood tests every 1 to 2 weeks to assess liver functions, renal functions, liver functions, electrolytes, and any signs of decompensation. Regarding blood glucose management, monitor blood glucose more frequently for diabetic patients, especially those on insulin or oral hypoglycemics. Adjust medication doses to avoid hypoglycemia. Regarding assessment of ascites and encephalopathy, check for signs of worsening ascites or the development of hepatic encephalopathy. Of course, this is a group when you advise them not to fast, but as we discussed in our case histories, some of them may fast despite your advice. So this is mostly for those patients. If either is noted, advise cessation of fasting. The sixth component of the guidelines is when to advise cessation of fasting, when you should tell them. What are the clear-cut criteria for that? The immediate fast cessation is required when the patient develops signs of dehydration like dark urine, dizziness, or fatigue. If the patient get confusion or altered mental status, that is the signs of hepatic encephalopathy. If there are electrolyte disturbances or severe fluid imbalances, or if there is severe hypoglycemia or hyperglycemia that cannot be managed. So if these conditions are present, you advise immediate cessation of the fast. Alternative religious practices, of course, if the patient is unable to fast, advise compensating through fidyas, that is feeding the poor, or making up for the fast after Ramadan when their health allows. Emphasize that Islam provides flexibility for the sick and not fasting is allowed in case of medical necessity. The seventh component of these guidelines is on the post-Ramadan care. Monitor for decompensation. If the cirrhotic patients have fasted during Ramadan, this is very important for them. After Ramadan, closely monitor for any signs of liver decompensation, such as fluid retention, jaundice, or encephalopathy, and adjust medications accordingly based on post-Ramadan health status. Nutritional support. Provide additional nutritional counseling to help patients regain any lost weight or improve their dietary habits after fasting. So the guidelines on the management of cirrhotic patients during Ramadan has these 7 components, and each component has its own sub aspects. And we need to cover all these. We need to be aware of all these to give the proper advice to such patients. So, dear colleagues, dear PGs, dear students, in a conclusion, the takeaway points are that for cirrhotic patients, fasting during Ramadan must be approached cautiously with individualized advice based on the patient's liver function, general health, and religious needs. Physicians should educate patients on the risks, monitor their health closely during Ramadan, and provide appropriate guidance to ensure safety while respecting their spiritual practices. With this, I pay thanks to all of you for being with me during these workshops. I hope I was able to educate you on the different aspects of the issue that in cirrhotic patients, what are the physiological changes which we see in any cirrhotic patients, and what are the physiological changes in Ramadan in a normal person, and when a cirrhotic person fasts, how these physiological changes they pose the complications, the challenges, and how we can implement that clinically, apply that knowledge to advise them to fast or not to fast, and when our advice should be based on the data and the real world data And because without having that data at the back of our mind, if we advise them in the wrong way, this is not only risk for their health, this is also a guna. So I'll request you to share these videos, these workshops to all of your colleagues, all of your juniors, all of your comrades. So the best possible care is extended to cirrhotic patients during Ramadan, and those who want to fast, they should fast, but if medically allowed, and if the close monitoring is warranted, and if it's going to be deleterious for those cirrhotic patients who want to fast but their health doesn't allow. So you properly counsel them, you properly educate them, and then they don't fast and go for the alternative options. So I end here. Inshallah, see you in another workshops. Till then, take care. Khuda Hafiz.